Thank you, and very much like to thank my colleagues for inviting me to speak about this topic as, I think, perhaps the sole medical oncologist here in this room on targeted therapies and where we're going with systemic therapy. And I think I'm going to just talk about where we're going in drugs in general and how it interacts with our surgical practice. These are my disclosures. So we base our staging on really what the ISLC have retrospectively collected and prospectively in some cases collected, which is the ISLC database. And I would suggest it's pretty much out of date already, because if you look at what's happening to stage 4B patients with the majority of the work that us medical oncologists deal with, you'll see that the 5-year survival is 0%. Patients don't survive 5 years. And that's really the adage that you've all been brought up with, certainly the adage that my respiratory senior consultants have been brought up with. But my mission is to tell you that that's not in fact the case. And in fact, drug therapy for lung cancer has really changed quite markedly. I'm persistently being told to treat my patient with chemo as if it's the only drug that exists. And in fact, I'd like to educate all of you to use the word SACT, S-A-C-T, systemic anti-cancer therapy, because I give different drugs to different indications at different time points, at different diseases. And we've moved from an era where we've been giving a lot of chemo to the late 2000s, where we started treating patients with NIBS, molecular targeted therapy, and about 2013 we started using checkpoint inhibitors in patients with lung cancer, otherwise known as immunotherapy, and these days we're just using mixtures of the variety of different ones depending on what the tumour likes and depending on which stage of disease we're treating. And this all really started with understanding what's going on in the genes of the cancer. And I certainly remember when the human genome was published. Time magazine had a similar article at the same time saying we could take this understanding of the human genome and really rationalize our drugs. And I remember at the time thinking, that's all total rubbish, isn't it? You know, it's not going to change what I do with my platinum tomorrow. But actually here we are quite a few years later, and actually it's that understanding of what's normal in the normal human being's genome that allows us to understand what is abnormal in the cancer genome, which when we pair it with drugs which switch off various cellular processes, allow us to personalize our therapy for patients at different time points. Now, this is one of the current up-to-date pie charts that you will see for patients with adenocarcinoma. And if you look at non-small cell squamous, you'll see a different pie chart. But really, it's adenocarcinoma that we're talking about when we're talking about molecular targeted therapy. So the second lesson to learn is tell me which subtype of disease we're dealing with, because an adeno I will treat totally different to a squame. With a squame, I'm really not interested that much in the molecular status. With an adeno, I really do need to know what we're talking about. And whilst the KRAS mutations are certainly very common, particularly in our smoking cohort, it's this wide variety of other somatic aberrations, I call them, because they're not all mutations. Some of them are fusions. There are a variety of other structural variants which are easily druggable by a variety of drugs that we treat. Now, if you go along to most MDTs up and down the country, your average oncologist is ordering an EGFR test, an ALK test, or an ROS test and a PD-L1 test. And this, by and large, determines which drugs we give to that particular individual. For my American colleagues and European colleagues, BRAF testing is not funded within the NHS, which is a real tragedy given that we have a highly effective therapy which has not been put forward for funding by the particular pharma company concerned. But this is really just the beginning of the avalanche of molecular variants, because we have a wide variety of molecular variants coming through, each of which have a variety of different drugs paired to them. And we won't be in a scenario where we'll be talking about, can I have a single gene test, please? We'll be just saying, right, stick it in the sequencing machine, and we'll be getting next generation sequencing results coming through. And if you're interested, some of you will know that the whole way pathology and genomics is organized within England has totally changed over the past few years. We now have 7 genomic hubs who will basically be pumping out NGS results for patients as routine standard of care within the course of the next few years. And those panels will change from really what we're doing, which is 3 genes. Most standard panels are 25 genes, and most centers are using anywhere anywhere up to 200 genes, because you've got to remember the sequencing laboratory has to give the results for the colorectal team, the urology team, the melanoma team, the sarcoma team. So why have different panels? Easier just to do a 200 gene panel for everybody and tell the lung boys what they want to know about their particular disease and any bells and whistles. But this allows us to divide our tumours into what I call the idiot's guide to drug therapy, which is those that are oncogene addicted. You need to know what the mutation is because they're the ones you're going to drug with the targeted therapy, and those that it doesn't really matter what the mutation is, they're addicted to immunotherapy. And this is a broader classification that we're coming to. And when you get it right, it will really work wonders. This is a patient, one of our first patients we saw with in EGFR mutation, widespread hemithoracic disease. Obviously, you could tell that patient was in a lot of trouble. We started her on an EGFR inhibitor, gefitinib, scanned her a couple of months later, and actually when you spoke to her, she said within 3 days of taking the tablet, her breathing had got better. She could get up the stairs by the end of week 1. She was off oxygen by the end of week 1. Actually caught up with her 2 weeks into the therapy. She's a totally changed woman. And that's just EGFR. This is really what we see routinely in ALK, although these days the ALK patients don't present as late as they used to in the days before we had ALK testing. And you can see that we have really quite marked responses. And I could say the same thing for BRAF. I could say the same thing for RET. I could say the same thing for ROS, blah, blah, blah. The problem is that this is not curative therapy. And after a period of time, be that 9 months, be that 12 months, be that 18 months, be that 5 years, all patients will relapse. So these are great drugs to have a great honeymoon with, but actually you're going to end up in problems ultimately. And you may want to switch drugs, but we need to work out how we're going to cure these patients far better than we are now. But actually, we're doing reasonably well. This is data from my colleagues in Colorado who I touch base with from time to time. They've looked at what happens to the ALK patients, and the median survival of your metastatic ALK patients is not 9 months, which is what you are brought up to know what the survival of metastatic lung cancer is, but near about 7 years or so, and which by definition means that 50% of that population are living more than 7 years. And we see this routinely in our clinics. But the disease, the treatment that we're treating now more and more using is checkpoint inhibitors, immunotherapy. And this is the long-term data from Checkmate 003, which is the first phase 1 trial in which patients were giving checkpoint inhibitors for the first time. This is the long-term data, and we don't have a 0% 5-year survival rate. We have a 16% 5-year survival rate. And what you can see is that you have lots of patients in whom you're not making huge impact, actually, but by the time you get to 2 years, you're probably going to live to 3 years, and by the time you get to 3 years, you're probably going to live to 5 years. And this is with 2 years worth of treatment. So you stop after week 96, about 2 years, and you just stop and can observe the patient and see how they get on. So we really are making huge inroads to our metastatic patients. So that was for your most sickest patient. Well, what happens if you say, actually, I'm just going to take my fit patient who I see for the first time. I'm not going to give them loads and loads of chemo and wait for them to relapse multiple times and then give them chemo when they're on the death's door. I'm going to give it to them as their first treatment. And this is a trial called Keynote 024, which randomized patients between standard platinum doublet chemotherapy and a single immunotherapy drug, pembrolizumab. This trial was shut early by the IDMC because there was a marked survival advantage for pembrolizumab. This is despite patients that were randomized to chemotherapy being switched over to immunotherapy after they had relapsed. So for patients in the first-line setting, these are patients with what's called PD-L1 greater than 50%. Chemotherapy in the metastatic setting is really making a huge difference. So we generally have 2 types of lung cancer, non-small cell lung cancer, in terms of a functional classification. We've got those that have got oncogene-addicted disease, and these tend to be your never smokers or minimum smokers, and these occur in about 15% of what walks in through the doors. And then we have the rest of them, and that works out to about 40% of what walks in through the doors, those that really thrive on immunotherapy. And you can name your particular immunotherapy agent of choice. They're all pretty similar, to be honest. So that's all well and good, Poppat, but actually, are we really going to cure anybody? Because, that's what it's all about. It's not all about adding a few months here and there. Well, should we be adding our TKIs, our tablets, to patients in the curative paradigm, to patients that you have operated on to make them live longer? Well, we started off by the medium risk patients. We took patients that had stage 3 disease and we treated them with chemoradiation, and then we said, well, let's just randomize them to an EGFR inhibitor, gefitinib or placebo. And in fact, shock horrors, those people that got the targeted therapy actually died earlier, died quicker than those that didn't. Now, these patients were all comers. They weren't EGFR mutant patients, so we weren't selecting at that point in 2008 the drug for the right target. But it certainly pretty much hampered the field because nobody wanted to play around with TKIs in stage 3 disease for the next 10 to 15 years. But we've got a variety of trials which have been looking at using molecular targeted therapy in the adjuvant setting. So you've done your lobectomy for stage 1-2 disease. I've given my chemo, and the real question is, should I be giving this patient an EGFR inhibitor if I know they have EGFR mutant disease? We have multiple trials which have looked at this. The first of this is the RADIANT trial. This randomized patients to receive 2 years of erlotinib or placebo. And what it showed is that there was no survival advantage. Patients did not live any longer. The TKI increased the disease-free survival, so it pushed back the time of relapse, but ultimately those that relapsed, that didn't get the drug, all got the drug when they relapsed, and they lived exactly the same amount of time. But more worrying, if you looked at where they relapsed, those that got the TKI tended to relapse in the brain because these drugs didn't in those days, get into the brain that well. So we haven't really been keen to use these TKIs in patients after surgery and adjuvant chemotherapy. Well, EGFR mutant disease, as you know, is not very common in the West. In Western Europe, it occurs at about 10% of the population. 2 weeks ago, I was in the Far East, and in the Far East, EGFR mutant disease occurs between 40 to 60% of the population, depending on where you live. So these guys have done a lot of trials. Chinese and Japanese have done a lot of trials in this setting, but we see exactly the same results. We see that you can push back the disease-free survival, but overall survival is exactly the same. So the oncological community at the moment is not really particularly enamored by disease-free survival in the operative setting and saying, well, look, don't use your drugs now, keep your tinderbox dry, because if you do relapse, for whatever reason, we can give you all the horrible side effects of the rash and the nails falling out at that point, rather than pushing back the time to relapse. But we have some newer drugs. We have a very nice drug called osimertinib. This crosses the blood-brain barrier, has very few side effects, and this trial is currently recruiting. Many of you will have been recruiting to this. This is patients with early lung cancer randomized to receive either osimertinib or placebo. We should have some results in 2021. Let's see what results we have. And my colleagues in the US will be recruiting to this excellent trial, Alchemist, in which all patients who have surgery undergo sequencing. They're randomized, if they're EGFR mutant, to a first-generation TKI, erlotinib or placebo, and in the ALK group to use crizotinib or placebo. And if you haven't got either of those drivers, you get immunotherapy. Because in other diseases, take my GISTs, that's an oncogene-addicted disease. We give adjuvant Gleevec, and those patients have a survival benefit. Take melanoma, that's BRAF mutant. We give adjuvant dabrafenib, trametinib. Those patients have a survival advantage. So why is it that in lung cancer we've never seen a survival advantage for TKI therapy? I don't know the answer to that question. Different disease, I guess. Well, what about checkpoint inhibitors? Poppat, you said they'd work really well in these patients that got riddled with disease, and then you bring it up to the patients that present to your clinic, and you're getting these amazing 2-year survival. Shouldn't I be just pumping my patients with checkpoint inhibitors after their surgery, or if they got stage 3 disease? I'm sure in this meeting you'll discuss at great length the Pacific study in which patients who are locally felt to be unresectable upon completion of their chemoradiation with stage 3 disease were randomized to receive checkpoint inhibitor for a year or not. And that clearly demonstrated a huge benefit in progression-free survival, but importantly also overall survival. And this is now pretty much standard of care for your patients that are PD-L1 positive and undergoing chemoradiation. The real question is, in patients with stage 3 that you operate on, where do we fit in checkpoint inhibitors? And I've got a few slides on that. So checkpoint inhibitors not only improve local control, because our radiation oncologists have been giving hyperfractionated radiation, hypofractionated radiation, trying all sorts of things, but also reduce the sites of distant metastatic disease. And anything that improves the brain is a good, brain relapse rate is a good thing in my book. And I would say if you look at the outcomes, the 2-year landmark of checkpoint inhibitor for Pacific, the outcomes really stack up very well compared to all of the other chemoradiation and even the intergroup study as well. But clearly we don't really have a lot of granularity of the population that went into this study, and you can imagine that every other manufacturer of checkpoint inhibitors, of which there are at least 5 major drug companies, if not the 30 companies in China which all have their checkpoint inhibitor in development, are looking exactly at this disease, and will have much greater granularity over the course of the next 3 years or so. Where are we going? It's not just durvalumab. If we look at pembrolizumab, manufactured by Merck, they've got a similar trial. The 2-year survival is exactly the same. If we look at our European colleagues, the Nicholas trial, this is run by the ETOP group, where we've been combining checkpoint inhibitors with radiation. Actually, it's quite safe to do that. We don't see a lot of pneumonitis. And if we look at the other checkpoint inhibitor, atezolizumab, and you give it either after chemoradiation or we give it together with your chemoradiation, we're seeing fairly similar results. These are all phase 2 studies. They're not going to change our practice, but they're telling us this is the strategic direction that we're heading in stage 3. Well, what about the radical setting? Well, in the adjuvant setting, we've got 4 big trials. They might be called different things depending on which part of the world you're living in. We have the US-led ANVIL study, which is randomizing patients after surgery and or chemo, if indicated, to nivo or not. We have the European Merck stroke EORTC study randomizing patients to pembro or placebo. We have the Roche Empower 10 study randomizing patients to atezo or best supportive care. And we have the Canadian AstraZeneca collaboration randomizing patients to durvalumab, all basically looking at the same thing. Will we improve survival with checkpoint inhibitors? But actually the area that I think is causing a lot of excitement is the pre-operative setting, the neoadjuvant setting. And my colleagues in the US will be well aware of this data. Patrick Ford was the first guy that presented this data initially, and in his centre he ran a very nice study actually, which is quite difficult to recruit to when I had a chat with him. Patients with operable disease were basically given 2 shots of nivolumab prior to their surgery, and then they underwent their surgery. Now each of these bars represents the percentage of tumour cell regression in the resection specimen compared to the preoperative biopsy. And we see that, and this is called a major pathological response rate when it hits 10%. We can see with just 2 doses of nivo, it's 45% of patients having major pathological responses. We see a slightly reduced, but I would say that probably the same sort of ballpark given the small numbers with the other drug called atezo. And what we've got here is we've got major shrinkage in the pathology specimen, but actually when you look at what's going on in the CT specimens, you don't see a lot of change. These tumours look pretty stable actually on CT scan. So we've got a big difference between what we're seeing on CT scan and what's going on within the pathology. And that fits in with what we know in the metastatic setting, because in the metastatic setting, patients say, hey doc, I feel good, are you going to give me my dose? And I say, hang on, your scan's just showing everything's getting worse. And actually, when you biopsy this, it's often just necrotic disease, as the checkpoint inhibitors cause a lot of inflammation. My Spanish colleagues in the operable stage 3 setting have been given concurrent chemotherapy together with immunotherapy prior to surgery. And this is a great phase 2 study where they combined chemotherapy together with nivolumab, and they showed a major pathological response of 80%. Now remember, our historical data based on the Spanish NATCH trial was 10%. So we really are making a huge difference in our induction regimes by the addition of checkpoint inhibitors, and time will tell, I think, as to how we place this combination. We have multiple trials ongoing globally looking at neoadjuvant checkpoint inhibitors with or without chemotherapy in the phase 2 setting, and I'm sure that ultimately this will change our treatment paradigm. So I'll close by saying that we have got lots of highly effective drugs for non-small cell lung cancer, which have revolutionised metastatic disease. TKIs do not improve survival, and we don't use them in a radical setting, apart from the Upper East Side of New York, as far as I can work out. Checkpoint inhibitors are standard of care to consolidate post-chemo radiation in stage 3 disease, and we've got multiple trials I'm sure will impact our patients with operable disease either in the adjuvant setting or neoadjuvant setting. One final slide. Obviously, you'd expect me to plug the BTOG meeting. Please put these dates in your diary, and if you're absolutely passionate about a particular surgical topic, please email me and I'll try and see whether we can fit it in. And with that, I'd like to thank you, and thank you for your attention.